So the battle for the mind and the body is fought every day in our communities. And yet it's our communities that expect fragmented care, which perpetuates the separation between the mind and the body. What role will you play in healing that divide? No matter where you sit, no matter who you are, no matter what you do, it is your responsibility to begin to change the way we think about health. That's not what I'm talking about today. I'm talking about something else, but I just wanted to start there. I was feeling good back there in the back, pacing a little bit. So my name is Ben Miller. I'm at the University of Colorado, where for the past 4 years, we have been working on a project here in this state, which some of you might have been involved in. My colleague, Maribel Cifuentes, who left, I don't think she's here, was the deputy director of this project. I'm using this today as an example of what's happening in Colorado that's so innovative because we just literally today did something that we academics love to do. We published a whole bunch of things on this study. So I'm going to be presenting to you things that just came out. Very excited about that. Yay, go academia. Advancing Care Together was a 4-year project, and it really started with the end in mind. It said, we believe that communities have better innovations than anything that I, as a research policy wonk dude, can come up with. So when I go into your communities and I see what you're doing to address behavioral health, public health, primary care integration, I want to study that in a way that brings to light your innovation, not takes my intervention and puts it into your community and then says do something with it. We wanted to study the innovation that was already happening. And we did this for 3 years, 4 years of the planning year. You can see here what all is in there, and I won't read this to you. I just kind of want to get to the good stuff here because I'm really excited. So today, in the Journal of the American Board of Family Medicine, we published these 8 articles. There was 8 articles, 3 commentaries, and 1 editorial. And I cannot tell you, I have yet to see in my career something that is as thorough and thoughtful in one location around the concept of integrating care as this. Now, granted, my name's on a few of these papers, and so I am relatively self-serving here, but it highlights all the different facets that goes into integrating care. You've heard it from this stage already today, what needs to be done. You've heard great examples clinically. You've heard great examples of administrative oversight that brings together different factions. You've heard Vatsala describe how Colorado is leading the nation in doing something that everybody else is dreaming to do. And we are. So this special issue highlights a few things, and I'm going to walk you through a couple of these papers just ever so slightly because you can read them, and they are pretty exciting. I think they're exciting. This might show how out of reach I am. Number 1, we have the paper on 5 organizing constructs for integration. Now, the beautiful thing about what I'm about to tell you is that these organizing constructs, they span all of healthcare. It is not just about clinical delivery. This is about community. This is much broader than just that one-to-one interaction between providers to help the patient. Okay, so the first one is around reach. Those of you that are familiar with the REAIM framework know that the first R in REAIM is reach. And essentially, as I describe it to my mom, it's kind of like denominators and numerators. It takes you back to fractions. How can you begin to determine how much your intervention made a difference in your community? Denominators can be defined multiple ways, and those of you that have already gone through school and have a degree that's much better than mine in this area, you can explain this better than me. But I will just tell you that this is an essential element in being able to explain what you did around integration. Number 2, establishment of a continuum of care pathways and addressing the location of care across the range of patient severity of illness. This is a beautiful thing here. This is when people get up on stage and they talk about no wrong door. Well, this is essentially that there are pathways for people to enter in to get behavioral health no matter where they present. And that fundamentally is not just on the back of primary care, it's on the back of our schools, our churches, where we get our haircut. How can we have multiple pathways so that people can have seamless access to something? This is almost unheard of because we believe as healthcare providers that everybody should come to us. Come to me when you're sick. Well, that's why healthcare is a little bit skewed. We need to disintegrate healthcare and get it back out into our communities and provide some type of assistance where there is no wrong door. Number 3, approach to patient transitions. We talk a ton about care transitions, but those of you that have done any type of delivery or clinical delivery understand that the first time a patient is asked to go somewhere else for something, they usually get lost. We all have gotten lost. The best question to ever ask a class, for those of you that will teach, is how many of you have been sick? And then based on the response, you can probably tell it's going to be skewed in one direction. People who have been sick in our system know how difficult it is to do everything that's asked of them. There's something cruel and unusual about that. So we have to figure out a way to transition patients. If we believe that one of the best places to address mild to moderate behavioral health conditions is in primary care, then what happens with those patients who have severe need? How do we manage that transition? Referrals, which I often describe as the new F word, referrals are not the solution to many of our problems. We've got to enhance ways that we have relationships between providers so that the patient understands that this is a seamless connection between people that are working together. And number 4, the location of the workforce. Location is everything here. I'll talk about workforce in just a second since Vasila called me out as chairing the committee for the state right now. But I believe that where we are in location to our community is everything. I can give you a million examples of this, but I'm talking fast because I want to get through it all. And then number 5, the last is participants' mental model for integration. All it takes is for you to get a room full of people that are working together and say, what is integration to us? And everybody has a different answer. Having a shared mental model on what we're working towards with integration allows us to achieve something almost in cohesion, almost together. If we don't have that shared mental model, then we're working towards something that is a different something. 3 key behaviors around integration. This is another paper that was published. So there's this fallacy that has existed for a long time when we consider integration. And I don't want to call it out because actually the gentleman that coined this thing that I'm now calling a fallacy is a really good friend of mine, and I'm going to his retirement party next week. So I won't talk about it too badly, but I do think that we have misinterpreted what integration is and is not. Because if you really look at, let me just pull them all up here. If you really look at what happens when you try and bridge the gap between behavioral health and any other medical service, 3 things happen simultaneously. And we as clinicians go in and out of these activities. We're not statically in one. The top one here, consulting. What happens if someone just calls you up or someone sees you down the hall and says, hey, I got a question about such and such? There's a fundamental consulting element there that is natural between any type of healthcare delivery. We consult regularly. Number 2, coordinating. Well, obviously you can see the definition here what coordination is, but if I'm trying to transition a patient between point A and point B, the coordination of care that's required there is really essential and built on the back of communication. Sometimes I'm the most appropriate person to see the patient. Sometimes it might be Dr. Byers. How we coordinate that is up to how we have set up our delivery system. This can be at any level, folks, so don't just get hung up on the clinical here. Number 3, collaborating. This is where we are working together. We are in the same space. We are doing something in the same community together. Now, what we observed with these data, which is why you should read the paper, not just listen to me, is that people go back and forth between these things every single day, sometimes in the same patient encounter. It's not just that I am a consultant there with my whoever provider doing something. It's that I am constantly involved in all of these activities. Okay, wrapping up here with my 2-minute warning. When we consider what needs to happen in the state of Colorado, based on some of the lessons that we've learned, I think that fundamentally one of the most important elements, which Dr. Goff already highlighted, is around workforce. We have got to create a workforce that expects something different. So look at the current workforce. How can we retrain who we've got? And I want to thank Dr. Holloway for this too, because he's given me the best bumper stickers in the world for talking about workforce. Number 2, how do we create the workforce for the future of the healthcare system that we want, not the one that we have? We currently don't have really good a pipeline to train providers for that system. We have a great pipeline to train providers for the system that we got, which is not always what we want. And then finally, this to me is the secret ingredient to change. When we are able to fundamentally address how our community can be involved in health, we change the game. And as I said, I didn't talk about this at the beginning, but the title of my talk is Change the Rules, Change the Game. If you really want to do this, you consider what role your community plays in addressing behavioral health. What role your community plays in talking about health differently so that behavioral health is just a natural part of what they mean when they say health. Finally, we must consider how to do this clinically, operationally, and financially simultaneously. Vatsala showed you this already, but many efforts have failed in healthcare because they take on one of these but not all 3 of these. Our responsibility is to make sure that simultaneously we are addressing these factors. Thank you.